Hello, today we will be talking about alterations in sensory input, cognition and neurological function. This content is in a variety of chapters as I will inform you where all the topics are located. So first we will begin with chapter 18, cognitive impairment. By definition, it has three components: sub-average intelligence, an IQ of 75 to 70 or below. 2, deficits in adaptive functioning of 2 or more in the following areas: communication, self-care, home living, social skills, leisure, health and safety, self-direction, functional academics, community use and work. And number 3 is its onset is before the age of 18 years of age. Early signs of cognitive impairment include dysmorphic syndromes like Down syndrome and Fragile X, irritability or non-responsiveness to the environment, like contact, voice, or movement, major organ system dysfunction, difficulty with feeding or breathing, gross motor delay, fine motor delay, language difficulties or delay, behavioral difficulties. They are often poor or slow feeders. They may have poor eye contact during feeding and diminished spontaneous activity. So what are some of the causes? Chromosomal abnormalities like Down syndrome, Fragile X are some, and we'll actually talk about Down syndrome. Infections or intoxications like rubella and syphilis, chronic lead ingestion, fetal alcohol syndrome, trauma, inadequate nutrition and metabolic disorders, phenylketonuria. This must be assessed and is always assessed when a child is born. Please note that they need to be 24 hours of age, and it is most accurately assessed after eating formula or breast milk due to the protein. Hypothyroid is another cause. Childhood meningitis, and here we're specifically talking about bacterial meningitis, hypoxia, and of course there are other issues as well. Diagnosis: history and physical, chromosome analysis, blood chemistry, lead levels, the ages and stages developmental screening test, a complete neurological test. Tests for assessing adaptive behaviors will include the Vineland Adaptive Behavior Scale and the Adaptive Behavior Assessment System. The Reschler Intelligence Scale for children provides an overall IQ score and aids in the diagnosis of learning disabilities. Early screening is important in high-risk individuals. So let's talk about the classification of cognitive impairment. There is a table in your text that gives the specific numbers, but it no longer has the expected observations. So I still will be addressing the expected observations here. So the level IQ. For mild cognitive impairment, here you're going to see anywhere from 50 to 55 to approximately 70 to 75. This is about 85% of people with cognitive impairment. The preschool, and typically when we look at preschool for the cognitively impaired, we're looking at ages from birth to 5 years of age. So maturation and development. Often the cognitive impairment is not really noticed by the casual observer, but this child is slower to walk, feed themselves, and talk than most children. They typically follow the same sequence in development as normal children. It's just slower. School age 6 to 21, so training and education, they can acquire practical skills and useful reading and arithmetic, typically to the 3rd or 6th grade level with special education. They can be guided towards social conformity, and they typically achieve a mental age of 8 to 12 years of age. The adult is 21 and over, and social and vocational adequacy. Here they can usually achieve social and vocational skills adequate to self-maintenance. They may need occasional guidance and support when under unusual social or economic stress. And they can adjust to marriage, but it would be very difficult for these people to have to maintain child rearing. So moderate levels, this is 35 to 40 to 50 to 55 of IQ. And this is about 10% of the people with cognitive impairment. Again, preschool. Here you're going to see noticeable delays in motor development, especially in speech. They do respond to training in various self-help skills. School age, they can learn simple communication, elementary health and safety habits, and simple manual skills. They typically do not progress in functional reading or arithmetic, and they achieve a mental age of 3 to 7 years of age. Adult, they can perform simple tasks under sheltered conditions. They participate in simple recreation. They typically can travel alone in the places they are familiar with, and they usually are incapable of self-maintenance. So typically they need to live with other people. So they should not be living alone. IQ here for severe is 20 to 25 to 35 to 40. And preschool here, they have marked delay in motor development, little to no communication skills. They may respond to training in elementary self-care like self-feeding. School age, they usually walk unless they have a specific disability that makes it so they're not able to. They have some understanding of speech and some response. They can profit from systematic habit training, and they typically achieve a mental age of a toddler. As an adult, they can conform to daily routines and repetitive activities. They do need continuous direction and supervision in a protective environment. And then lastly is profound, and this is below 20 to 25 IQ. Preschool, they have gross delays in all areas. They have minimal capacity for function in sensory motor areas, and they really do require total care. Obvious delays in all areas for the school age in areas of development. They show basic emotional responses. They may respond to skillful training in the use of the legs, hands, and jaws. They do need close supervision because they only achieve a mental age of a young infant. As an adult, they may walk, but they need complete custodial care. They may have primitive speech, but they do benefit from regular physical activity. So physical activity is very important for all of these stages. So treatment, there is no cure, but we really want to try to prevent any of the causes that are preventable, like fetal alcohol syndrome, lead poisoning, trauma, and there are others as well. So as a nursing, we want to investigate their learning abilities and deficits, and then educate using effective teaching strategies, promote optimal development. Early intervention programs are systematic programs of therapy, exercise, and activities designed to address the developmental delays in disabled children to help them achieve their full potential. They need to be in a safe environment. We want to promote self-care skills, encourage play and exercise, provide a means of communication. Please note that verbal skills are typically delayed more than any other physical skills. And there are several adaptations or types of communication devices that are available to facilitate selection of the appropriate picture or word, and this will help them with communication. Behavior modifications, we want to reinforce desired action. So when a child is doing something you want them to do, give them lots of positive reinforcement. Using time out, procedures are appropriate forms of behavioral control. Opportunities for social interaction and infant stimulation programs should begin at an early age. Sexuality information must be provided and helping families plan for future care. You want to give parents information for resources and rights regarding education of their child. Under Public Law 101-476, the Individuals with Disabilities Education Act of 1990, basically states that states are required to provide educational opportunities for all children with disabilities from birth to 21 years of age. Please note, I will not ask you to tell me what the law is. It's just for your information. Home care alternatives. Some parents may choose to give their child up for adoption after diagnosis. Foster care, group homes, semi-independent living, state and private institutions are other alternatives. If the person lives with their family, there are day programs, special vocational education, and respite care services available. Often the respite care services are available through regional centers. So Down syndrome, this is the most common chromosome abnormality of a generalized syndrome. About 95% of cases are due to an extra chromosome 21. So this is trisomy 21. And this occurs in women 35 years of age in 1 in 350 live births. Women who are 40 years of age, 1 in 100 births. So you can see how it drastically increases as a woman does get older. But please note, 80% of Down syndrome are in women under the age of 35. So this information is not in your text, but paternal age is also a factor, especially in men 55 years or older. So there's a wide variety of clinical manifestations for Down syndrome, and there is in the box 18.2. I'm just going to highlight a couple. I'm not going to read the whole thing. Eyes and ears, here you're going to see that oblique palpebral fissure. It's an upward outward slant. Inner epicandal folds. Excuse me. Nose and ears, small nose, a depressed nasal bridge, also called saddle nose. Mouth and neck, here you're going to see a high arched narrow palate, a protruding tongue, hypoplastic mandible, and then you may also see problems with teeth alignment as well as a delay in teeth eruption. They can have periodontal disease and skin laxicity of the neck and excess skin of the neck. With the heart and the chest, you can see congenital heart defects, and the common ones that we typically see here are your atrial septal defect and your ventricular septal defect. Abdomen and genitalia, here you're going to see a protruding, lax, and flabby abdominal muscles. You might see umbilical hernias, cryptorchidism. Hands and feet, here you can see broad, short hands and stubby fingers, a wide space between the big and second toes, a plantar crease between the big and second toes, and you can also see a palmar crease, transverse palmar crease for the hands. Musculoskeletal, they may have hyperflexibility and muscle weakness and hypotonia, often referred to this as the baby being sort of floppy. Atlantoaxial instability. And you might even see for the skin, dry, cracked, and frequent fissuring. Other things that you can see would be things like reduced birth weight, learning difficulties. A typical IQ is roughly 50, so it's in that neighborhood. Hypothyroidism is common, impaired immune functioning, an increased risk of leukemia, and then they also have an early onset of dementia in 1/3 of these patients. Diagnosis, chromosome analysis, low intelligence, and cognitive impairment. So we do want to assess for heart defects. We already mentioned that they're commonly the septal defects, and we'll be checking for this using an ECG or 3D echo. Monitor for increase in hearing and eye problems. They also can have an increase in respiratory tract infections, hypothyroid, like we already mentioned, delayed in growth and sexual development, and that increased incidence of leukemia. So if the child is involved in sports that might stress the head and neck, we do need to do an X-ray for that atlantoaxial instability. And if they have issues with neck pain, weakness, or torticollis, that would be a concern. Another risk is a high risk for spinal cord compression. And other concerns here would be persistent neck pain, changes in sensation, and then a loss of established motor skills or a loss of bowel or bladder control if they had bowel or bladder control. Treatment. Again, no cure. We want to correct the anomalies that we can correct, routine history and physicals, immunizations, sight and hearing testing, and then we just want to promote the optimal health and development for this child as much as possible. Autism spectrum disorders. So basically, autism spectrum disorders, also called ASD, are complex neurodevelopmental disorders. The definition of ASD is based on two behavioral domains: difficulties in social communication and social interaction, and unusually restricted repetitive behavior, interest, or activities. So manifestations and diagnostic evaluation. Typically, children with ASD demonstrate core deficits primarily in social interactions, communication, and behavior. So failure of social interaction and communication development is a hallmark of ASD. They also have an inability typically to maintain eye contact with another person. They have an avoidance of body contact and language delay at a very early age. They have limited functional play. They may interact with toys in an unusual or odd manner. ASD children may have significant GI problems. Typically, constipation is a common symptom that can be associated with acquired megarectum in children with ASD. So that's the typical significant GI symptom that we see. So what are some warning signs in autism? Basically, if we see no babbling by 12 months, no pointing or using of gestures by 12 months, no single words by 16 months, no two-word phrases by 24 months, and a loss of language or social skills at any age. These require immediate hearing and language evaluation as well if any of these develop. Early recognition of behaviors associated with ASD is critical to implement appropriate intervention and family involvement. The American Academy of Pediatrics has recommended that pediatric healthcare practitioners they basically administer 2 ASD screenings at ages 18 and 24 months using a valid screening tool. A developmental history is essential. They also need to do physical examinations for genetic syndromes or neurologic findings. And then often, young children may present with behavioral difficulties. What are we going to do? The most promising results have been through highly structured and intensive behavior modification programs. In general, the objective in treatment is to promote positive reinforcement, increase social awareness of others, teach verbal communication skills, and decrease unacceptable behavior. It's very important to provide a structured routine for the child to follow. This is key in the management of ASD. Planning and implementation, again, providing highly structured and intensive behavior modification programs. These help to reinforce positive behaviors and decrease negative or inappropriate behaviors. We want to decrease environmental stimuli like sounds and lights, maintain a safe environment, provide close supervision. Self-abusive children need protective mechanisms in the least restrictive manner possible. Promote parental coping, maintain the hospitalized child's daily routine as much as possible to minimize stress. Remember, these children like routine. Encourage activities and specialized education programs to the child's ability to promote optimal growth and development. Because physical contact often upsets these children, try to minimize holding an eye contact as necessary to avoid behavioral outbursts. This is something that you might see you need to do when a child in particular is hospitalized, because remember, the nurses and care providers in the hospital are all strangers. Care must be taken when performing procedures on, administering medicine to, or feeding these children. Children with ASD need to be introduced slowly to new situations. Communication should be at the child's developmental level. Just make it brief and concrete. Parents and family teaching. Parents need expert counseling early in the course of the disorder. Teach the family proactive care that reduces the child's risk of injury. Educate the parents about behavior modification methods. Support groups and experts in ASD really help to provide parents with the needed education and support. And it's also nice to refer the parents to the Autism Society of America, and there is a website as well as a phone number. Next, we are going to talk about attention deficit hyperactivity disorder. This is in chapter 16. Know that this is a developmental disorder involving inattention and or hyperactivity. This is more common in boys and in girls. The diagnostic criteria for attention deficit hyperactivity, it's actually broken down into two sections. The A section is the inattention, and then the B section is the hyperactivity impulsivity. So first we're going to talk about the inattention section. So here the signs and symptoms would be they have 6 or more for children up to age 16, and 5 or more of the signs and symptoms for people that are diagnosed 17 and older of the following symptoms of inattention. Note that these have persisted for at least 6 months to a degree that is maladaptive and inconsistent with developmental level. So what are these signs and symptoms of inattention? Basically, they often fail to give close attention to details or make careless mistakes in schoolwork, work, or other activities. They often have difficulty sustaining attention in tasks or play activities. They often do not seem to listen when they are spoken to directly. They often do not follow through on instructions and fail to finish homework, chores, or duties in the workplace. And this is not due to oppositional behavior or a failure to understand the instructions. Again, they often have difficulty organizing tasks and activities. They often avoid or dislike or are reluctant to engage in tasks that require sustained mental effort, such as schoolwork or homework. They often lose things necessary for tasks or activities, things like toys, school assignments, pencils, books, or tools. They are easily distracted by extraneous stimuli, and they can be forgetful in daily activities. So the second component, so that hyperactivity, impulsivity, here you could see again 6 or more signs and symptoms for children up to age 16, and then 5 for people 17 and older. And the symptoms of hyperactivity need to persist for at least 6 months to a degree that is maladaptive and inconsistent with the developmental level. So what are they? In the area of hyperactivity, we're going to see that they often fidget with their hands or feet, or they squirm in their seat. They often leave their seat in a classroom or in other situations in which remaining seated is appropriate. They often run about or climb excessively in situations where it is not appropriate. So in adolescents or adults, they might actually complain to feelings of restlessness because they have actually learned to cope in terms of knowing that they can't run around, but they still have that subjective feeling of restlessness. Often they have difficulty playing or engaging in leisure activities quietly. They're often just on the go as if they are driven by a motor, and they often talk excessively. Now, the things that we will see in terms of impulsivity, they often blurt out answers before questions have been completed. They have a hard time waiting their own turn, and they will often interrupt or intrude on others, like butting into conversations or games. Other things that we need to take a look at is that the hyperactivity or impulsivity or inattention that caused impairment, these were present prior to the age of 12. It occurs in 2 or more settings, and there needs to be a clear evidence of impairment in social, academic, or occupational functioning. And then the symptoms do not occur exclusively during the course of another mental disorder. Treatment. We want to focus on family education, counseling, proper classroom placement, environmental manipulation, behavioral therapy, and possibly they may need medication. So medication for children age 5 years and over and young people, the most common medications are psychostimulants. Methylphenidate, also called Ritalin, enhances dopamine and norepinephrine levels, which inhibits impulsiveness and hyperactivity, which can improve attention and task performance. It is typically taken in the morning and at noon. Again, we want these medications to be effective while they're at school. Side effects can include anorexia, so we do want to give this with meals, sleeplessness, so again, we give it early, headache, weight loss, abdominal pain, an increase in crying, irritability, cardiovascular stimulation. Avoid caffeine due to decreasing the medication's effectiveness. You want to regularly schedule reevaluation of the child that are taking these medications to determine the effectiveness of the medications, as well as detecting and evaluating any side effects. We need to monitor the development and health status, especially the growth and blood pressure in these children. And we also want to assess family interaction. Parent information. So really teaching them to minimize outside distractions if the child needs to sleep or concentrate. There must be consistency at home and at school. Children with ADHD need an orderly, predictable, and consistent classroom environment with clear and consistent rules. Homework and classroom assignments may need to be reduced, and more time may need to be allowed for tests to allow the child to complete the task. Verbal instructions should be accompanied by visual references, such as written instructions on a whiteboard. Schedules may need to be arranged so that academic subjects are taught in the morning when the child is experiencing the effects of the morning dose of medication. Regular and frequent breaks in activity are helpful because sitting in one place for an extended time may be very, very difficult for this child. So what you may want to do is list all of the activities before school starts, so that way they know what they need to do, and you can even have like a checkoff system. What are they going to be doing during school? And then again, having a list of what it is that they need to do after school. Provide positive reinforcement for meeting the goals. So if they've got 5 of 7 checkoffs each day, then they get something positive. Maybe they get to have a treat or going to the park. They also need appropriate discipline for behavior that is not desirable, like timeouts, removal of privileges, an increase in chores. Note that this must be done immediately for behavior modification. We want to promote self-esteem by pointing out the child's positive behavior. So anytime they're doing something you want them to do, give them lots of praise. That's super important. Parents need emotional support too. They also may need parenting classes because they have a very active, kind of a difficult to handle child. Chapter 18, here we're going to talk about strabismus. This can also be called squint or malalignment of the eyes. So it is called esotropia if there is an inward deviation of the eye, and exotropia if there's an outward deviation of the eye. So, pathophysiology, it may result from a muscle imbalance or paralysis, poor vision, or congenital defect. Because the visual accesses are not parallel, the brain receives two images. And note that a lack of binocularity after 2 to 4 months of age is considered abnormal and must be treated to prevent amblyopia. So clinical manifestations, this child may squint their eyelids together or frown. They may have difficulty in focusing from one distance to another. They may have an inaccurate judgment in picking up objects. They may have an inability to see print or moving objects clearly. You might see them closing one eye to see or tilting their head to one side. If this is combined with other refractive errors, you might see any of the other manifestations that are listed for refractive errors that are in your textbook, such as diplopia, photophobia. You can see dizziness as well as complaints of headaches. So the treatment really depends on the cause of the strabismus. It may involve occlusion therapy, which is the patching of the stronger eye, or if necessary, they may require surgery to increase visual stimulation to the weaker eye. The earlier the diagnosis, the better, because this can help to prevent vision loss. Chapter 14. Here we're going to talk about bullying. And note that this is a recurring activity that intends to cause harm, distress, or control towards another. Most often occurs in school hallways or on the playground where supervision is minimal, but peers are present to witness the attack. Cyberbullying involves an electronic medium to harm or bother another individual and can be more harmful than traditional bullying because the attack can have an instantly wider audience and it can reach them much more quickly. And this also allows the bully to remain anonymous. Children who are targeted for bullying often have internalizing characteristics such as withdrawal, anxiety, depression, low self-esteem, and reduced assertiveness that might make them an easy target for bullying. Bullies are generally defiant towards adults. They are manipulative and likely to break school rules. They have aggressive attitudes, a positive view of violence, a lack of empathy, and they may experience or witness violence or abuse at home. Boys who bully tend to use physical force. This is referred to as direct bullying, but girls usually use bullying methods such as exclusion, gossip, or rumors, and this is referred to as indirect bullying. The long-term consequences of bullying are significant. Future problems of bullies include a higher risk for conduct problems, hyperactivity, school dropout, unemployment, and participation in criminal behavior. Chronic bullies seem to continue their behavior into adulthood, negatively influencing their ability to develop and maintain relationships. On the other hand, victims of bullying are at increased risk for low self-esteem, anxiety, depression, feelings of insecurity, loneliness, poor academic performance, and psychosomatic complaints. They might complain of feeling tense, tired, or dizzy. School personnel play an important role in implementing anti-bullying interventions in schools. However, research has recognized that involving the whole family in anti-bullying programs greatly increases success. Next, we're going to talk about enuresis and encopresis. This is in chapter 16. Enuresis. This is urinary incontinence in a child who should be potty trained. Primary enuresis is the child was never potty trained. Intermittent, this is they have occasional dryness. And then secondary, this is bedwetting in a child who was trained for 6 to 12 months. And this one tends to be associated with stress, infections, and sleep disorders. Nocturnal bedwetting usually stops by roughly 6 to 8 years of age. And to diagnose enuresis, the child must be over 5 years of age and wet the bed at least 2 times a week for 3 months. Just remember that the bladder volume as the child is the 2 plus the child's age. So if a child is 3 years of age, then the number of ounces that the bladder will hold is 5 because 3 plus 2 is 5. Assessment questions. So here we want to find out, are there any newer chronic stresses in their life? Do they have urgency or frequency? Are they often thirsty? Do they have diabetes? Do they have burning on urination? Do they have a UTI or have they had a UTI in the past? Here you can see we're trying to rule out medical conditions. Treatment, fluid restriction. So the fluid intake is limited in the evening, typically, um, no more than 7 to 8 ounces, depending on the child's age. And obviously, we want to limit it before the child is going to bed. Bladder exercises, these include things like having the child drink a large amount and then have them holding their urine as long as they can. The child practices stopping, voiding midstream. So it's sort of a start, stop. So they will void and then they will stop the stream and then they will continue. Exercises continue for at least 6 months. Timed voiding. So the child with diurnal enuresis is instructed to void every 2 hours and then to use what we call a double voiding pattern. This trains the bladder to empty completely and avoid over distension. Enuresis alarms, this is basically a detector strip that is attached to the child's underwear. The alarm sounds and a buzzer will alert the child when the wetting occurs. So basically, this will wake the child up so the child can then get up and finish voiding in the bathroom. You want to allow the child to use this alarm with a doll because this will help to increase their comfort with the system. A reward system. So we want to set realistic goals for the child and reinforce dry days or nights with stars or stickers on a chart. Sometimes medications will be used, antidiuretics and antispasmodics, depending on the problem. Desmopressin given an hour before bedtime may be prescribed in cases of nocturnal enuresis. Oxybutynin for diurnal enuresis can be given to relieve urgency, spasms, and frequency from bladder irritability. Dietary changes can include avoiding fruit and fruit juices, carbonated and caffeinated drinks, and citrus fruits after 4 p.m. Also avoiding high protein foods and salt. Treatment occurs over a 6 to 8 week period, and then gradually, if they're on medications, they will taper the medications off over approximately a 4-week period. Know that as a nurse, you just need to be aware that the treatment varies with the cause. You do want to provide emotional support to the child and the parents. Don't embarrass or punish the child. Also, don't refer to these as accidents. And enuresis really isn't an accident because accidents can be prevented. And we do want to have the child assist in changing the sheets. So this just helps them to know that they are participating in their care. Encopresis. So this is defined as a repeated bowel movement into the bed or clothing at least 1 time per month for a period of at least 3 months. And it is not due directly to a physiologic condition or substance. And this occurs in an individual who is at least 4 years of age. Some predisposing factors are inconsistent training and or stress. So primary is basically they were never potty trained by the 4 years of age. Secondary is they were continent and now they are not. The problem is either voluntary or involuntarily holding BM, causing constipation, resulting in lower bowel dilation and incomplete, excuse me, and incompetent inner sphincter. Loose stools leak around the hard feces. And note that the child might not be able to feel the need to defecate and may also be very painful. When they've been holding that BM so much, often what happens is they stop feeling that need to defecate. Often incontinence can occur after a bath, Causes can be environmental changes, having a new sibling, moving to a new house, changing schools, having to use new or unfamiliar toileting facilities. Constipation, chronic or severe, may impair the usual movement and contractions of the colon, and this also can lead to fecal obstruction. Other causes can be abnormalities in the digestive tract and other medical conditions. Psychogenesis, encopresis, this is the soiling caused by emotional problems. This can be related to a disturbed mother-child relationship. And next, how are we going to manage this? Oh, well, just kind of FYI, I already mentioned that over time that the child can lose the urge to defecate on his or her own. Also know that what can happen is the child may have diarrhea, or they can have a loose leakage around their clothing and pass small amounts of hard stool, and this can indicate that the diarrhea or loose stool leakage is going around a hard fecal mass. So now management. Physical assessment, so they'll do a rectal examination, abdominal x-ray, they will do dietary modification. Often they'll eliminate milk and dairy products, increase in high fiber foods, increase in fluids, stool softeners, toilet rituals to encourage the child to establish normal defecation. For fecal impactions, they may need to use mineral oils, osmotic laxatives like lactulose, Miralax, or magnesium hydroxide. Mineral oil should be avoided in patients with dysphagia or vomiting because we don't want them to aspirate those. Nursing, education on normal defecation, toilet training, treatments, and medication will take place. We want to encourage the child to sit on the toilet for 10 to 15 minutes after meals for intervals of 10 to 15 minutes. Provide quiet activity. Make sure the toilet is comfortable, non-threatening, in a non-threatening environment. Place a footstool below the feet. This helps to relax the abdomen and makes them more comfortable and makes it more easily for them to have their bowel movement. Positive reinforcements, again, stickers praising the child. If they have a certain number of check marks on their praise board, we can give them an award, again, maybe extra trips to the park. Adequate fluid intake and dietary modifications, as we already talked about. And know that behavioral therapy and psychotherapy may be necessary. And then please reassure the child that they can have a normal function. Also reassure the parents that as well. So that concludes the first portion of the objectives for this week. Please make sure that you watch the other recording for this week to complete the objectives. Thank you and have a nice day.